Thank you, Warren. Maybe while people are walking up, I'll ask the first question.
Sure.
I have read and have been told that there's two main issues. There's many, but these are two main issues to achieve what you're talking about. One is, in order to collect all this information and learn from it, we have to have a dictionary of terms that we share so that we're using a common vocabulary. And the other is that we have to have interoperable systems in our records. And is that true? And are there policy issues that could be put in by, let's say, CMS, which pays half the healthcare bills, so that we could achieve what's talked about over and over again?
So that's, I think those are both very important questions. Absolutely, semantics and being able to properly describe what we're capturing on patients is incredibly important. Actually, I think that there are a number of groups that are really focused on that already. But certainly the NCI itself has a long history of developing common data elements for a lot of things. CAP, for instance, the College of American Pathologists, has very detailed checklists for how you capture data from pathology standpoint. The comparative, so PCORI and the comparative effectiveness folks, they've been really pushing definitions that will end up in EHRs. So I think there are already a lot of activities that are moving us toward having highly standardized data elements for outcomes. But is it far enough? I don't know. And then your second, sorry, your second question was?
Whether
interoperability
we need interoperable systems.
So I think interoperability means different things to different people. From my perspective, if we have good semantically defined data that we can access from our existing systems, we can build interoperability between them. So to me, that's really the definition of interoperability. Dan.
Dan Macy's, the University of Washington. So as a fellow informatics geek in cancer, I guess first I think the audience needs a little more, a few more words on de-identification. You had said that identifying an individual makes their identity known. But of course, this observation that a relatively few number of characteristics, whether they were ICD codes or a little bit of DNA sequence, makes you unique does not make you identified, right? So what makes you identified is then a naming source. You have some way to link that biological uniqueness to, things that we think of as being personally identifying names, addresses, account numbers, those sorts of things. Now, having said that, that's the difficult part of proving that samples can't be identified, is that the proliferation of naming sources is going wild, right? People are posting their genomes on the web and that sort of thing. Now, that is the preamble. In the world of informatics, you can control risk by either doing something technological, encrypting data or removing data, or you can control it with policy, meaning you get sanctioned for misusing the data. You agree to have some acceptable use policy. What are your ideas with respect to NCI's or your own view of the possibilities of having an orderly view that data that is highly unique but not necessarily natively identifying, of controlling that residual re-identification risk with advances in policy about acceptable uses and people agreeing that any powerful technology can be misused. You can get in your car and drive on the sidewalk and kill at least a few people before someone will stop you. You can, but they don't tell them not to make cars because they get used for bank robberies, right? So we're held to a standard that in data that seems to be unachievable given the native power of the stuff. So what do you think about policy versus technology with respect to both re-identification and the use of identifiable data?
Sure. So first, I appreciate you bringing up that point because I really did gloss over it. I think there was the very first speaker said, I'm going to gloss over a lot of really important things, and please don't hold me to that. And I guess I'll echo that. However, with respect to identification, re-identification of data, it is, I think, a big deal in part because it's a big deal to people in our society. So the ideas of privacy are really, we hold them all quite dear. I think, though, that that's changing generationally. So you see people now posting things on Facebook really that are accessible to the world that I wouldn't consider telling anybody. But so I think there's a change in perception of what is private. But back to your your underlying point. When you look at the use of EHRs, for instance, in a hospital, you're allowed with relatively low barriers, basically saying, I want to see this patient, to search and look up data on a particular patient. That is audited, it's reviewed, and if it was done for improper reasons, you can be fired. So I think from a policy standpoint, we need to get to that same standpoint as a country. How do we make the data available? How do we audit that it's being used properly? And what are the penalties for not using it appropriately? So is that getting at your question?
Yes, thank you.
And I think I'm sorry.
Margot Frommer, reporter for the ESCO Post. Getting back to the availability of data, I agree, I think everybody in this room agrees that the more data that's available generally about cancer, the better. However, the vast majority of people in this country, let alone the rest of the world, have no idea, A, what the data is, what it means, B, how to use it to their own advantage or to those of their family members. And I worry about all this data that's available that nobody knows what to do with or think they know what to do with, but do it wrong. And I would like to know what your thoughts are about raising the level of, for lack of a better term, raising people's cancer IQ in this country so that they know what to do with all of these many, many layers of data.
So I think that's a great question. I love the idea of a cancer IQ. So I think that there's not a simple answer to that, unfortunately. And again, I heard a number of folks talking this morning about how hard it would be, in fact, if just next-gen sequencing data and systems biology approaches to next-gen sequencing data was exposed to clinicians, let alone to the average public member. So I think that when I say I want the data to be accessible and as broadly accessible as possible, that's different than it's going to be all interpretable. So maybe your underlying question is really what's the appropriate way to make people's data available to themselves, and how do we help them interpret it? So I think that one of the questions that we've been struggling with, and we meaning the healthcare community, is I believe that a patient owns their own data, but of course when it's lab values, when it's imaging, that data was paid for by an insurer. The institution had an investment in making sure that the equipment was working properly, and some institutions, and I don't necessarily mean academic ones, may not feel as comfortable releasing the data directly to the patient. So I think that we have to address some of those questions with respect to individual level patient data first. So how do patients get a hold of their data, and how do they start to understand it? And frankly, that's a much bigger problem than I know how to deal with, because it takes lifetimes of training sometimes to understand some of the data that we're now aggregating. Yes, I'm a big fan of seeing it all out there, because I think there are some very smart people in this world that if they had access to the details, and I don't necessarily mean identifying details, but all the details of, for instance, the outcomes and treatment and as much genomics of patients with a given disease, let's say prostate cancer, then we might be able to know a lot more about the outcome of the disease. I think we would know a lot more. So I don't have an easy explanation for how, or an easy answer for how we can make data more clearly articulated to most patients. And I'd love to hear other people's thoughts on that. So how do we help explain all the data that's available?
Might be a good topic for a workshop.
Hi, I'm Gwen Darian from the Cancer Support Community, and actually the last time I was in this room was at the Cancer Informatics meeting where we spoke about a lot of the same things. I have a question which I wanted to ask you before, actually. I may have another question after that question, but as you said, you glossed over some things and went through some things very quickly. But when you were talking about open access, you paired that with patient desires. And I wasn't certain if you were talking about patient desires being a barrier to open access or if patient desires were a catalyst to open access. Because in my experience as a longtime patient advocate, most patients who give their data would like it to be shared.
So I glossed over some of my own history. So I've been at Northwestern for 20 years. I've been part of our cancer center for 15, and I've dealt with patient advocates. I shouldn't say it that way.
Please.
I've had many interactions. They've been great interactions with patient advocates, and I would say that the reason I put that in there is I don't think we do enough to support what the patients actually want us to do with their data, with their specimens. So it's how do we, and I've heard this from many patients and patient advocates, I want my tissues and my information used to solve cancer, writ broadly.
Right.
And how do we respect that? How do we make that possible?
Mm-hmm. And I would just suggest that maybe that's something that can be made more explicit as we're giving these kinds of talks, because I think that I think sometimes privacy is a red herring in these conversations, and sometimes it's just code for something else.
Right.
I think there's also a huge difference between patients and survivors and cancer survivors, and I mean I've told millions of people I'm a cancer survivor, as opposed to people that have not yet been diagnosed with cancer. And so I think we often conflate those two things as well. So I think there are multiple areas where some more discussion and more nuance can come in.
Well, and certainly thinking about it from a consent standpoint, I think it's hard often to ask patients as they're first diagnosed with cancer to meaningfully think about what does it mean to release their data.
Right.
So for instance, that's probably not the time to ask for true consent.
Absolutely. And they're often more concerned with something beyond themselves. They're concerned with their family, something else. But thank you.
Sure. Thank you.
Bill, are you waiting?
Enjoyed your talk. Bill Dalton from Moffitt and Tugen. On the topic, I think the consent and informing and continuing to inform is a continuous process. We don't ask patients to consent if we're doing it correctly once. We continue to inform them, especially if we're using their data and their tissue. So I think it's an ongoing effort to continuously inform them. One thing we did at Moffitt, I'll get a little parochial, but we created an effort and a protocol to ask patients if we could follow them throughout their lifetime by them donating their medical data and specimens. And in so doing, in creating the protocol, we created a patient advocacy and ethics council. And we asked them the very question that you posed of, what do you want back? I mean, the intent was obviously to try to match them to the best therapy, but many patients won't need it. But we wanted to be able to give something back to everybody that participated. They immediately said, give us back our own information in a usable format that we can understand. Mm. So that was the birth of the patient portal to looking at their own data. And it's an ongoing effort. And it's just, which includes a page that they can visit their own consent anytime they want, because it's a protected PIN number, and so it is a secure website that they have access to. The popularity was incredible. In fact, in the last 3 months, 100% of all new patients at Moffitt have created their portal. So it's something they desire. The satisfaction scores are also extremely high. But I just want to, I think this link of informing patients and consenting patients is just a continuous effort.
So I absolutely agree with that. And I've had many very positive interactions with patient advocates over the years. And one of the things that I've heard over and over again, it is really a process. And how do you use that? In fact, that touching the patient with an opportunity to inform them, to educate them, and make that really part of the rest of their experience, the rest of their survivorship. And I think, again, and I didn't have time to talk about this in any of the slides, but something that strikes me as a opportunity that becomes very informative from a consent standpoint is if we can give them then the ability to remove that consent at any point in time, then they have control. And that's exactly where they need to be. They need to have control over how their data is used. And until they have that control, they don't feel comfortable. And frankly, I can't blame them. So how do we give that control back to the patient? Or not back, actually, to the patient.
Mm-hmm.
Okay, last question.
Yeah, that was actually, that leads right into the question that I had. And first of all, ditto to everything Gwen said about patients really wanting this information to be used for the right things. We've done a lot of research on what patients want to do or want done with their data. My question, though, is around, I'm hearing a lot about informing patients, educating patients, and sort of, it still feels like their role is very secondary in this conversation as opposed to having a primary role. I mean, it's about them and they're giving information, and I don't hear us talking about what, how they are really being put in the driver's seat in all of this. So can you speak a little bit more to that, and specifically maybe what your plans are at NCI for really making sure patients are, primary when we talk about information sharing and gathering?
So first, I apologize for that. I think that's where being trained as a scientist, you tend to take an objective view of things, and that means you tend to distance yourself from actual people, which isn't really my intent at all.
Sure.
Absolutely, I think that it's the patients need to be front and foremost. And I think that's true that's the reason all of us are in cancer in the first place, is we want to see the patients get the best possible outcome they can. So how to do that, I'm not absolutely sure. And I've already been talking to a number of the patient advocates that I personally know. But I'd love to hear thoughts from the community as well. How do we better engage the patient advocates and the whole patient community?
Thank you.
Okay, well, let's thank our speakers, and we'll not take a break. We're going to move right into the next session. Thank you both for a very, very nice presentations. The next session is bringing evidence-based medicine to clinical care, and Mike Caligari is chairing it.